Asthma deaths and emergency room visits have not improved in years. And it's not because we don't have better medicine, it's because uncontrolled asthma is still being missed. This episode is part of an ongoing campaign to help doctors and patients identify uncontrolled asthma earlier. This one is intended for healthcare providers. We will have a patient-focused one coming soon. But if you are a patient, stick around because there's definitely something here for you too. For more information, please go to controlyourasthma.org. I'm Kortney, bringing you the patient perspective, joined by my fabulous co-host, Dr. Payel Gupta, a board-certified allergist and immunologist. Our guest today is Dr. Cherie Zachary, the president of the American College of Allergy, Asthma, and Immunology. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank Sanofi Regeneron for sponsoring today's episode. While they support the show, all opinions are our own, and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now, let's get to it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Today we're welcoming back Dr. Zachary. If you haven't caught our episode with her, you can check it out. We talk about her role as the college president. So check it out so we won't get into a huge long intro, but welcome back, Dr. Zachary. If you could give us who you are and why you're here to talk about uncontrolled asthma with us today.
Well, thank you very much. I am Dr. Cherie Zachary. I am the current president of the American College of Allergy, Asthma, and Immunology. And I'm here to talk to you about uncontrolled asthma today because if we look at the data from the CDC and from Healthy People 2030, what we find is that with regard to asthma measures, ER visits, hospitalizations, morbidity, and mortality, we are stuck. We have not been able to make a dent in those for some time. So, this is a very important topic of discussion.
Yes, I think that the message with asthma is something needs to change. And it hasn't been the mortality rate, which is the disturbing part. And so now we're trying to figure out what else needs to shift and how better can we support patients in helping them understand what control actually means and looks like. And that's why this is such, as Dr. Zachary said, such an important topic. We really need to figure out a different way of addressing control and making sure that patients and providers really understand what good asthma control looks like.
Absolutely.
And so today's episode, we're really focusing on the provider, and that doesn't mean just an allergist, right? That also means a GP or anyone who touches someone with asthma. So I think just as a really quick laying the foundation, what do we mean when we talk about uncontrolled asthma and kind of where are we going with that for providers? What do they need to understand that you want to change in terms of how they're talking about asthma with their patients?
I think what we want to change is for them to understand that if you have patients that are using 2 or more courses of steroid in a year, that is something you need to consider. If you have patients that have been in the emergency room, urgent care, that is definitely something that you need to consider. If patients have been hospitalized, you definitely need to consider that. All of these things that from a provider point of view are things that should lead you to think that I've got a patient whose asthma is not controlled.
So Dr. Zachary, what is the definition of control that we would like providers and everyone to use right now?
Well, if you look at the ACT, that's pretty much gives you the definition of what control is or what control is not. So if you've got patients that are waking up at night more than 2 times per month, if you got patients who are using albuterol apart from exercise more than twice per week, if you have patients who are ending up in the emergency room and urgent care, those are all indicators that you as a provider need to take a look at and say, this patient's asthma is not controlled.
And ACT is the asthma control test, right?
ACT is the asthma control test. And that is the one that most providers at this point in time are using.
And those are questionnaires that most asthma patients should have filled out at some point during their care. But ideally, we have patients fill that out at every visit so we can really get subjective measure.
And I honestly think that's really important because I've lived with asthma my whole life, and I went through a period where I never talked about it to my doctor because it wasn't something I was worried about. But during seasonal allergies, I was still having problems and I was waking up at night and it got worse, but at a certain point I just thought that was how I lived and I wasn't ever given one of these control tests. So I always just forgot about it, right? So I was wondering, is there something that providers might be missing in terms of starting that dialogue with patients who maybe have lived with asthma their whole life and they've just kind of normalized their symptoms?
Absolutely. The challenge is that patients, as you have well stated, normalize their symptoms. They say, well, during my pollen season, this is when I have a problem. Otherwise, I'm perfectly fine. But the problem is, during those seasons, I have a couple of ER visits, a couple of urgent care visits, a couple of courses of oral corticosteroids. I'm using my short acting rescue inhaler more than 2 times per week apart from exercise. And so it leads you to understand the asthma is not controlled. And so, from a provider point of view, if you don't ask some more probing questions, you may miss the fact that you've got really a patient who's got uncontrolled asthma if you see them outside of those seasons.
Yeah, you hit the nail on the head with me. Exactly what happened is I would go to the doctor and I wasn't having symptoms at that time, so I just totally forgot about it, which is crazy to think about sometimes.
And it also allows providers, since that is the focus of the conversation today, it also allows providers to have that reminder of the important questions that we need to be asking when we're doing an asthma visit. Because especially primary care providers, they are managing so many different conditions that it's a lot to remember, really, to be honest with you. There are so many things that we need to factor in for every single condition, but this just helps providers make sure that they're asking the right questions. And there's other questionnaires like the AirQ that is also another questionnaire that we're moving to because it gives us more of a 12-month picture of how the patient's been doing. And so there are different parameters that we can use to really figure out if the patient is under control or not.
Right. What you don't want to do is to have a metric that, okay, we measured this over this amount of time, check the box, the patient is fine, and the patient really is not fine. You want to be able to cue the provider to ask more probing questions when they need to.
And I think that's a really good time for us to talk about how there is a push to create a consistent language in terms of talking about uncontrolled asthma and a consistent set of questions that providers are asking. Dr. Zachary, can you tell us a little bit more about that?
Yeah, that was part of what we were working on, is to trying to bridge that gap to make sure the patients were speaking the same language as the providers. What we didn't want to do when we worked with the Allergy and Asthma Network was to have a different language for the patients and a different language for the providers. We wanted everybody to be speaking the same language or speaking the same dialect so that when the patients come in to their provider with the information, they're already speaking the same language as the provider. And so both of them can be on the same page to say, I think we need to address this more.
And what are you doing to change that? So, how are you promoting that language to both the patients and the providers? So, say I'm a provider right now, I'm not, but pretend I am, and I'm trying to say, okay, how do I make sure that me and my patient are speaking the same language? What's happening so that that's actually going to work out?
I think part of that work with Allergy and Asthma Network has been to empower patients to understand what questions they should be asking of themselves so that they realize from a patient perspective, hey, wait a minute, my asthma is not as well controlled as I thought. Give them the tools and the language so that when they meet with the provider, I, as the provider, can say, wait a minute, if this is going on, your asthma may not be as well controlled as you thought. And I need to ask more probing questions of you. It's more than just, oh, okay, well, I saw you out of season. You're not using your short acting bronchodilator more than twice a week. Hey, we're good. Oh no, wait a minute. You've been in the urgent care or the emergency room twice since I've seen you. What else is going on? What's going on seasonally? What's going on environmentally in the home? What are the allergies that may be leading to this? How can we proactively adjust this? And do we need to adjust your maintenance medication so that we don't have this as a precipitating factor?
I also want to clarify that part of what we really need to understand is that when your asthma is not controlled, what we're worried about is that there is an additional amount of inflammation in your airways that shouldn't be there. Inflammation or swelling is something that we can't get rid of quickly. We really need to manage that over time if we want to use the right medications. So oral steroids or systemic steroids. We've had many episodes on why these medications are not good, and they can be used to cut down the inflammation. We also use the inhaled steroids, and we also have medications like biologics that help with that underlying inflammation. And so when you have inflammation or swelling, and then you get a viral infection or you're exposed to an allergen that you didn't know you were going to be exposed to, then that puts somebody at risk of having an exacerbation that then can lead to hospitalization and sometimes death, right? And so it is those people that are not controlled that will end up having those issues. And the issue with asthma is that sometimes the normalization of symptoms where you're like, I'm always coughing. That's just a part of my chronic condition. That's a part of my asthma. Or I'm always using my inhaler, but I have asthma, so that's normal. We need to make sure that patients and doctors understand that asthma is a waxing and waning condition, but there are telltale signs that there's more inflammation present in the airways that shouldn't be. And I think that's the messaging that we're really trying to hone in on and figure out how can we make sure everyone understands there is inflammation that needs to be better controlled. And those ER visits are a telltale sign because ideally for myself and Dr. Zachary, none of our asthma patients should ever need to go to urgent care or emergency rooms if we're managing them the way that we want to be managing them and have them under control the way that we want them to be under control. So that's really the key thing.
And I think also communicating to providers that from an allergist perspective, if you've had a patient in the emergency room or the urgent care, we consider that a treatment failure. And that is something that we're going to evaluate and say, wait a minute, this is a treatment failure. Now I need to go back and look at your therapy and adjust your therapy appropriately. It's not something that we take as, oh, you were in the ER, you got a course of prednisone, we're fine. No, we consider that as a treatment failure and something that we need to evaluate and assess in terms of how we adjust your maintenance medication preventatively so this doesn't happen going forward.
I really love that. I feel like we don't talk about that enough, that this is a treatment failure. I think when you put it in those terms, especially for providers, it gives them a concrete, this is not okay. And I was actually talking to one of my patients who is the doctor in the PICU, where that's the pediatric intensive care unit. And we were talking about asthma and how he's seen more asthma in the last couple months and how he actually saw, unfortunately, a fatality in an adolescent asthma patient. And just in the last couple months, we had this really real conversation because even though they manage asthma patients in the PICU often, he wasn't really aware of the asthma guidelines and how and when we would choose a biologic, for example, for a patient. And he said that patient in particular had been in and out of the emergency room and the hospital. And all he saw on that patient's medication list was an inhaled steroid. And I said, well, that is the number one problem. And so, it's just these kind of conversations that I've had with my emergency medicine colleagues, with my PICU colleagues, my intensivists, the people that work in the adult ICU. All of these doctors say the same thing. Well, we see that they're not on anything but these medications, but we're not really sure when they should be on higher level treatment. And so it's really, how can we educate everyone that, hey, this is a red light?
If they're in the emergency room, You're seeing a patient who has a treatment failure. They can be on inhaled steroids, doesn't matter. You've just seen a patient with a treatment failure, and that needs to be addressed as a treatment failure. It should not be addressed as just give them steroids and send them back. That's a treatment failure, and the system needs to decide very clearly, what are you going to do about this treatment failure? It needs to be viewed in that context. Because for the allergist, if we have any patient in the urgent care or the emergency room or the hospital, we already know that's a treatment failure. We've got to do something differently. And I think giving the tools for our colleagues, whether it be emergency room, whether it be pediatrician, whether it be family practice, whether it be internal medicine, to understand if they've hit this point, you have a treatment failure, you must do something differently.
And Dr. Zachary, to be honest, I would say that sometimes even allergists and pulmonologists need that education. Because this child did see pulmonary in the hospital. He did on numerous visits, according to this patient, doctor friend of mine. And so he had been touched by a specialist and was still not on appropriate therapy. And he did die. And there were telltale signs that he was not doing well. And he had had multiple ER visits before that.
But this needs to be communicated. If they've hit the emergency room, if they hit the urgent care, if they hit the hospital, you have a treatment failure that must now be addressed. You cannot simply go back and do what you've normally done. You have to address this and decide how you're going to step up therapy.
So this is really the crux of what this episode is supposed to be about. There are these control questions that will really create consistency around this topic. And there are 5 questions, and we can go into each 5 separately, but I'll quickly mention them. In the past 12 months, aside from inhaled steroids, have you needed tablet, liquid, or injectable steroids more than 2 times? In the past 12 months, have you been to the emergency room or urgent care for asthma symptoms? Over the past month, have you used your quick relief inhaler more than twice a week? Over the past month, have you woken up at night due to asthma symptoms? And over the past month, have you had to slow down or reduce your daily activities due to your asthma symptoms? So I think we've really touched on that emergency room, urgent care aspect, but we can talk about why the other 4 questions exist and why they help us determine if someone's in control or not.
Absolutely. So, for example, you have patients that will tell you, well, I only use my albuterol before exercise. Well, that's like 6 times a week. Okay, something needs to change because if your asthma is really in control, we'd like not to see that. That should not be something that people think is a normal part of asthma. If you're waking up at night due to asthma, that needs to be a red flag that tells you this patient's asthma is not controlled. And slowing down over your normal daily activities, that's going to require a bit more probing questions. So if you just ask a patient that, no, I haven't really had to do that. Well, tell me what your normal activities are. How many flights of stairs can you actually go up before you get short of breath? Well, maybe one. Okay, that's a no fly zone. For kids, for example, can you keep up with your classmates at school? Are you at the front of the class when you're exercising, the middle, or the back? Probing questions for adults. I don't have to go upstairs. I don't have a problem going upstairs. Well, where's your bedroom? Well, I moved it down to the first level so I don't have to worry about going upstairs. It's going to take a bit more from the provider to ask a few more simple probing questions.
So it sounds like the other questions beyond the ones from the ER and the oral corticosteroid use is really about, is this asthma changing the way that you live? So is your asthma shifting something that you're doing? And sometimes it's really subtle and you don't realize you're doing it, right? But over time, you're making these changes, and that's a sign that the changes you're making are because you aren't breathing properly, right? And like Dr. Gia mentioned, is if you have this underlying inflammation, there's one thing that can happen that can trigger you to end up in the ER. So my sign was I would freak out if I would go to bed without my rescue inhaler on my nightstand. That was a red flag. I couldn't sleep soundly because I knew that if I had an attack, I would have to get out of bed, stumble around, and find it. So that's a red flag. And that's something that I was doing for so long that I didn't realize it was a problem. And so that's what Dr. Zachary is saying is like, us as patients, we don't realize the changes that we're making. And now as providers, you have to ask more probing questions so that you make sure that, can you go up a flight of stairs? Is walking from the parking lot to the grocery store, does that feel like exercise to you? Is that hard for you? Do you make sure that you park closer? Have you changed your grocery store so that you don't have to walk as much? Are these small things that we're doing that can show that we have uncontrolled asthma? And those are what those questions are trying to get down to, right? Is, have you changed your lifestyle because of your disease?
Right. And if we can access or get a better history with those probing questions, we might be able to adjust patients' medications so that they don't end up in the emergency room, urgent care, or hospital. So that's the importance of those.
I think that oftentimes, because of the waxing and waning nature of asthma historically, providers also feel confused to a certain degree that, well, asthma can get worse at times, like a viral infection or with exercise. So we should expect that. However, I think that what we're saying is that we shouldn't be expecting that. And so, Dr. Zachary, can you comment on that?
Absolutely. If you know your patient's triggers, the goal of therapy is that when they hit that trigger, they don't have an asthma flare. That is the goal of preventive therapy. That is the goal of understanding my patient's trigger is dust mites. My patient's trigger is when they go to see the kids in Colorado at altitude. My patient's trigger is birch pollen or ragweed pollen. Knowing the patient's trigger, I adjust the medication to account for the patient's trigger so that when that trigger hits, they have no increase in asthma symptoms. They have no required for oral or parenteral corticosteroids. They do not end up in the emergency room. They don't end up in urgent care. They don't end up in the hospital. That's the point of maintenance medication, is to adjust for those triggers so there is no increase in asthma symptoms.
Is that also part of having an asthma action plan, is that you have your maintenance, but then you know that like if birch pollen is a trigger, you do something differently in that time?
That is part of that, but for some, yes, and yes, and yes. For patients who you know what their trigger is, in most cases, you will adjust their medication ahead of time to prevent any exacerbation during that trigger. For other patients, you're going to adjust their medication and bring them from here to here so that we're consistent throughout the year, because most asthma patients have more than one trigger. And so you really want to get the maintenance medication in a place where the asthma is very consistent. Because one of the things we know is that the inflammatory response of asthma is not neutral. When patients have asthma exacerbations and the inflammation is not controlled, there are long term issues with regard to lung function, spirometry, exhaled nitric oxide that we don't want. We have loss of lung function, which can look in some studies not dissimilar to a smoker. So we really want that inflammation really, really controlled. We don't want this up and down. We want it really pretty controlled and very stable.
Yes, that is so important. And it's also important to recognize that the reason that our primary care colleagues are so important is that there aren't as many allergists and pulmonologists out there as we would like. And so having our primary care colleagues on the front lines really understand who are these patients at real risk and at most risk, and understand what that means is really important so that those patients that really need us can get to us. And so if anyone calls me from my primary care colleagues and I don't have appointments, but they're telling me, oh, this patient's been to the emergency room or ER multiple times for their asthma, could you see them? Instantly, I'm like, yeah, this is going to be a priority patient for me, I will absolutely see them, because it would break my heart if I didn't see them and then it was that next emergency room or urgent care visit that ended up being a fatality or death. And so I think that as allergists and pulmonologists, we understand the urgency of those consults. And so if our primary care colleagues come to us with that request, I think all of us would put a priority onto that patient. And that's also, I think, an important message to get out there, is just that even though there's not enough of us for these asthma patients, especially, we are here for them and we would love to get that nudge.
Absolutely. And I've had my PMDs call and say, I got this emergency. And I look at my nurse and say, put them in. They've got to be seen because this is mission critical. We've got to get this fixed. We don't want any more statistics that any things that are preventable. We want to be able to really manage these patients well.
So, what I'm hearing is that asthma is A, preventable, and B, if it's looking like it's uncontrolled, it's something that should be addressed very, very fast and not, oh, we can send you in a week or two to the specialist.
And what I would say is that with integrated healthcare systems, our providers have access to us in a way that they might not have had 20 years ago. There is great opportunity from a systems point of view for these patients to say, wait a minute, this patient is in the emergency room, they're in the urgent care, something is wrong. And there is the opportunity from a systems point of view to have the system, I'm thinking outside of the box, but to carve out administrative time to say, hey, Dr. Zachary, we've got these patients, they've been in the urgent care, they've been in the emergency room. Can you review their case to say, what do we do next? That's a systems issue, and that's a way that we could, as allergists, really help our primary care colleagues to say, this person should go here, this person should have this person needs to be in my office yesterday or 2 months ago, get them in here. And with integrated EMR and healthcare technology, I think this gives us an opportunity by which we can actually impact this disease.
Ah, the gold standard. I wish that we could do that effectively. And I think peer to peer consults is something that I've done as another avenue of helping patients. That would be the gold standard. And I do hope that integrated systems are looking into that, and especially with AI and the capabilities there, to really find the patients that need to be seen more urgently than others and triage in that way. And I think that that is the future that we're hopefully looking at, is trying to figure out a way that that patient that, got an appointment because of their allergic rhinitis or something, maybe gets moved further down the list, and somebody with a critical asthma can get moved up on the list. So these are all things that I think on a systems level we would love to address. And right now, the part that we're working on before that system level is just making sure we're all speaking the same language.
Absolutely. We have to make sure the patients and the providers are speaking the same language so that providers know when they need to step up therapy, when they need to contact allergy specialists to say, here's what's going on with this patient. Can I get this patient into your clinic sooner because these metrics are not being met and this patient is failing?
If you don't mind, I'd like to just take a quick step back just to be clear on what we mean by speaking the same language. Is that having the same definition of what uncontrolled asthma means? Is that what speaking the same language means in this context?
Yeah, it does because providers are used to using, for example, the ACT. So if patients come in with different metrics from that, that creates a disconnect with the provider saying, well, this doesn't look as bad because it doesn't meet the ACT criteria that the system is set up and I'm used to using. So it is trying to make sure that we're all on the same page in terms of communication so that when the patient comes in with, I got these things going on, the provider can look and say, oh, yeah, okay, this does mean we have issues that we have to address.
Thank you so much. That was very clarifying for me. I just wanted to make sure that I was speaking the same language as you guys.
Yeah, because otherwise, if the patient is speaking one language and the provider is speaking another language, the language the provider is speaking is the ACT, and the patient's language doesn't line up with that, then the provider may not recognize the patient has a problem in the first place. So we've got to make sure that everybody is on the same page.
Yes, I think the important part is just recognizing that these 5 items that we mentioned earlier, those 5 questions, is what everyone, providers and patients, should be thinking about before their visit, right? And so if a patient goes in and they're going in for their asthma visit, they know that these 5 questions are the things that they really need to be thinking about. Like, how have I been doing in the last 12 months, specifically around the use of steroids, around emergency room visits in the past month? All of these questions are very important. And actually, I said right before a visit, but really anytime, right? If any of these answers change, that's an indication that you need to be making an appointment to see your doctor. So, any of these questions, having a yes to any of these means that you need to be scheduling an appointment with your doctor in order to figure out what needs to change in your asthma management.
Absolutely correct. These are designed to cue patients to say, if I've had a yes to any of these things, I need to talk to my doctor.
And on the other side, it's also a cue for providers, especially primary care providers. These 5 questions should always be asked to your patients. And if there's a yes to any of them, then either you as the primary care provider should increase therapy, or if they're already on the highest level of therapy that you feel comfortable initiating, then that patient needs to be seen by a specialist.
That is exactly correct.
Dr. Zachary, can you tell us what are the patients that doctors should be looking out for who are most likely to have uncontrolled asthma?
Oh boy. Okay. Patients that are more likely to have uncontrolled asthma hasn't changed in 20 plus years, unfortunately. I wish it had, but it had not. The patients that are most likely to have uncontrolled asthma are Afro American and Puerto Rican American, although there is some data currently that the rate of asthma in Mexican Americans is increasing as well. Black American females postmenopausal, African American pediatric patients are greater risk. Those things have not changed a bit. And so those are your patients. If you have them, you need to have your radar out to say, these are the patients I'm most likely to get in trouble with. And I need to really make sure that I ask probing questions when they're in the room to say, are you really controlled or are you not? Because the data has been very clear, very unchangeable over 20 years, that these are the patients that get in trouble with their asthma.
Cherie, to end this episode, I think we've kind of talked about it, but what can providers do differently to make sure they're reaching patients who might not be advocating for themselves in the exam room?
Well, I think making sure that you have really good communications with those patients, that they connect with you, that they trust you in a way that they're going to tell you things they may not otherwise tell you, that we have systems that can reach out to patients. I think we have to do a better job in those areas because we know that the patients that are most at risk are more likely not to have access to our care, whether it be telemedicine, whether it be electronic, whether it be in person. We have to do a better job from a system point of view and also from a provider point of view to really communicate with our patients and let them know your poor asthma control isn't your fault. I think sometimes patients feel that my poor asthma control is my fault. I've failed somehow. And we need to make sure that patients understand no, that's not the case. We're here on your side. And if your asthma is not controlled, then we're going to work with you to get it controlled. And it's not a negative reflection on you.
Dr. Zachary, I have to say that really resonates because as a patient, sometimes you feel like you've done something wrong or you've been bad and you don't want your doctor to. I think you're afraid of shame, perhaps, as well, saying that this is what's happening. And you don't want someone to say, well, that's your fault when you feel like maybe it wasn't. So I think having that non-judgmental, it's not your fault, it's a chronic condition, and just explaining to them that there are things that you can do to make sure that you are feeling better. So I just have to say that I always go into an exam room feeling like I did something wrong, even though I feel like I haven't. And if you take that away, I think a patient will be more open.
Yeah, you always, as a provider, want to create a space where the patient can tell you anything and feel comfortable telling you anything. Are you still smoking half pack a day? Yep. Are you ready to quit yet? Nope. Okay, fine. I'm here for you when you want to. I'm not going to judge you for it, but you let me know when you're ready for the next step and we'll go from there. You want to create that open space where you can really talk to your patient about anything and they can tell you anything and feel comfortable.
Thank you so much, Dr. Zachary, for sharing this new language that we're trying to standardize for both patients and providers. Every time I meet doctors or allergists and they tell me that asthma is something that should not be racking in any deaths whatsoever, it always shocks me because as someone who normalized symptoms for so long, I didn't realize how big a deal asthma is. And I do feel like as a culture, sometimes we downplay the severity of asthma. And I'm really happy that we're changing that dialogue and that we're opening up that messaging to say, this is why you don't want to just normalize your asthma symptoms. This is why you can control it because we have so many options now than we did 30 years ago to have your asthma under control. So it's not a hopeless journey, and there's no reason any of us should be living with uncontrolled asthma.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.